My name is Mahesh Narayanan. I'm the managing partner at Neuvation Ventures. I'm not sure if you actually had an intro or if you want me to intro myself.
Great, and then if you could pass along the microphone to Jeff Tronk, managing partner for Malbec Capital Partners.
Hello, Marty, thanks for the invitation. Arthur, thank you. I'm managing partner of Malbec Capital Partners, as Arthur said. We're an advisory consultant and merchant bank. Frankly, right now our focus is on real estate and renewables. However, I was involved in a significant healthcare transaction. Spent 2 years of my life doing that. Prior to launching Malbec Capital Partners, I was a senior MD at JP Morgan and chief financial officer of the asset management business. And I also was chief operating officer of a large hedge fund called Third Point. And here I am.
Great, well, thank you. And then next one is Maxim Owen, partner of Wavemaker 36 Health.
Thank you, Arthur. Wavemaker 360 Health. I'm a partner there. We're a seed stage venture fund, 100% focused on healthcare. So we're backing 2 guys or girls in a garage, investing in next generation of healthcare technology. Fund is based in Los Angeles. I'm based in our New York office here. Prior to that, I was leading the ventures team at a company called Startup Health, which is another large early stage digital health venture fund.
Great, well, thank you so much. And I will start like in the same order, kind of like trying to figure it out what's going on with the future of the healthcare, anything from telemedicine through, you know, the new diagnostics that are available for at home. And then I'd like to start with Mahesh, if I may, asking what are the current innovations in healthcare? What is a new and exciting for your company?
Yeah, absolutely. So I'm going to mention that innovation, we're focusing primarily on innovation towards neurodivergence. So that includes anything with autism spectrum disorder, ADHD, dyslexia, learning disabilities, as well as genetically inclined disabilities like trisomy 21, Down syndrome. And so part of what we're looking at on our end is within the deep tech side, and moving that over to the health tech space. So this includes AI, robotics, machine learning, and then also kind of miniaturizing much of the larger technologies that we have into, think of the Star Trek tricorder, and really bringing it to what we call the at-the-point diagnostics, and then really diagnosing it sooner rather than later. When it comes to robotics, it's not just about machines kind of building things. It's also, we could use it as a learning tool for children and even later stage adults with some of these neurodevelopmental diseases, and use it for social interaction, use it for learning as a SaaS type of scenario, and then kind of provide the robotics as the basis where all the other tools are built around. And so there are quite a lot of developments there on that side. But also when you look at the biological side of things, we're also trying to bring in technologies like cell therapies and gene therapies over to the neurodevelopmental space. So they exist in, predominantly in oncology and immunology, but trying to bring those type of technologies over to where we can actually use it in the neurosensory and neuromotor skill space. I think those are really where we think the innovations moving forward, and those are what we're looking to invest into.
Well, that sounds very exciting. I wanted to actually ask Jeff, because Jeff has experience in actually doing a deal in the space, but that's sort of in the past. But kind of looking into the future, we can always use the past as an analogy, and one is actually making a deal in the healthcare. So I was wondering if Jeff, you could tell us a little bit about one of your experiences in dealing with the healthcare and one of the deals that you were able to close back and whenever it was that you did.
Yeah, it frankly was a fascinating deal. I got introduced to a company called CareFinders Total Care. It's a home health care company essentially aids to patients who are older or in need. And much of the business was Medicaid related. And I initially dropped in to support them in figuring out their finances, operations, strategy, technology, et cetera. And the reason why I took on the assignment, I was just fascinated by the founder, an M&A lawyer who saw an opportunity in a fragmented industry, and she cobbled up some money to purchase a platform company, and then made 30 acquisitions over 6 years of small. There's tens of thousands of small home healthcare companies. What happens, when you do that, it starts getting heavy, especially, if you don't have the right folks on board and the right technology to integrate those companies. But the assignment changed during my time there from consulting on operations, essentially, to managing an M&A transaction to sell the company, which we ultimately did to a public company, strategic.
Great. Well, I wanted to move to Maxim and ask him, since you're actively investing into the space, what are the companies that you're investing in right now? What is your interest right now?
Yeah, so in its broadest concept, we're looking to invest in companies that can do one of three things. That's broaden access to care, lower the cost of care, or improve the quality. Those are the kind of three metrics that we think about when we invest. Extending that, if you look at the sort of historical innovation in healthcare, 1.0 was getting all of our medical records from paper into electronic medical record systems. 2.0 was maybe speaking to your doctor over the phone, or a sort of easy online consultation for a flu or a UTI. And now what we're doing is moving into sort of 10-minute 3.0, where we're kind of able, through the internet and technological innovations, to actually treat more chronic, complex conditions in an end-to-end manner. So we're sort of investing to benefit, to help companies achieve that goal of caring for more and more people virtually, and hopefully in doing so, lowering the cost. And if you lower the cost, then there's kind of some room there to hopefully improve outcomes. So those are the kind of things that we're investing in. If you think about the unbundling of the hospital as a kind of front door into the general healthcare system, we're trying to find lots of different doors and get more people plugged into the system that way.
Sounds
we
good.
invest at the seed stage, which is kind of, usually the company might have a pilot or an early customer, and so we're very much backing the team and their vision for the future of healthcare. So
how early of the stage do you invest in? Is it like concept to pre-FDA approval, or?
Our minimum threshold is, what we say is, somebody somewhere willing to pay for the product. So it's deliberately loose in that it could be a contracted customer, it could be 100 beta users if it's a consumer business model. Our real kind of restrictions around valuation. So we won't invest in businesses that are worth more than $20 million for a first check, which means we typically play in the kind of $5 to $15 million valuation range of business.
So are those checks like contingents? Like, let's say there's a company that has the IP but hasn't been really proven yet that it's going to work. Are you willing to actually take a risk?
Yeah, but very much so. So we like to take that early stage risk, and we often like to be the first institutional investor into a business, kind of generally after a friends and family or an angel round. One of the partners on our team is an ex-deputy director of the FDA's West Coast office. So we feel like we have a little bit of an inside track on some of the regulatory approvals that need to happen for some of these companies. And so that kind of enables us to have the conviction to go prior to any real sort of commercial track.
Cool. Hey, I wanted to jump back to from Maxim to Mahesh. Mahesh, I know that, I looked it up on your web, and then I don't understand. A lot of those things are new to me, but you have a neuro developmental disorders that you're heavily interested in solving a problem. So can you tell us a little bit about what it is that you do in that specific field?
Yeah, absolutely. So similar to Max, we also invest in early stage, very much in the pre-seed to seed, and some very early Series A. So this field is still very nascent when it comes to innovations. A lot of them are still in the lab. And so there are two folds to what we do. One, we identify these technologies very early and try to build strong teams that can actually take it to market and then fund those teams once they get there. And also identify companies that have already established a product market fit, how, very similar to what Maxim said, one or two customers that we can talk to, figure out this is really something that others are going to pay for. A lot of the companies that we do fund, they have currently a niche in the space, but the applications can be very broad. For instance, we have one company that's looking at more medication management, and that's an issue across the board, neurotypical or neurodiverse. A lot of people don't realize that with neurodiverse individuals, overdose is actually one of the largest causes of death in this population. And so having that being addressed here, we have a population of both parents, family, as well as individuals who are willing to adopt very, very quickly to new technologies and are willing to pay a lot for it too. A typical ABA therapy session for a child in the autism spectrum is about $30,000 per year. So these are individuals that are willing to pay quite a lot to get care for their children or their family members. So we're able to try and get innovation into their hands, get it to the point where we can now get it to other individuals who are not necessarily within the neurodivergent space. And so that's kind of part of what we do. But really, in terms of the field itself, it's anything that has to do with developmental disorders. And so anything that is stopping them from having what we would call a neurotypical life. So social skills, learning skills, motor skills, and anything that we're able to help in that category, and primarily both from a diagnostic perspective. So early the diagnosis, early the intervention, much better quality of life. So it really brings down the burden in the healthcare space very, very much when you're able to diagnose someone in the autism spectrum when they're 12 months instead of when they're 36 or 48 months. And so that's really what we're trying to do, is bring that care early as well as diagnosing early. And there there are so many different ways, and it is very much a saying in the neurodivergent space: if you met one person in autism or ADHD, you met one person in that particular spectrum. So you cannot apply what you've seen here to the next person over. But we have gotten to the point, both in the genome sequencing as well as healthcare delivery, to personalized medicine. And we've done that in other areas like oncology already. So we're really bringing those learnings from those areas. And part of my background has been in immuno-oncology as well as neuroscience. So bringing those studies and making N of 1 into a possibility for this particular group is what we're looking to do, and trying to make that get to as many of these individuals as possible, not just within the United States or developed countries, but also underdeveloped countries.
That's if I just wanted to continue on, like, one more question to you, Mahesh. So most of those diagnostics that you're doing, are there like programs that are going to be remote or is that still a tools for the doctors in the house to make the evaluation faster? Which direction are the companies going nowadays?
More and more, and primarily because of what code was able to do for the telemedicine space, a lot of this is going very much remote into the cloud. So another example I can provide is we have a company that can analyze videos. So if you upload a 2 to 3 minute video of your child playing or talking or doing some kind of physical or mental activity, we can actually monitor pretty much frame by frame if there are indications of either ADHD or autism, any other type of neurodevelopmental disabilities. We can really identify pretty much anywhere between 80 to 90% accuracy. And this is on par, if not better, than most ABA therapies, because when you go to an ABA clinic, these are clinicians, and so there is human error and there is a variety. So there are some that are really good and some that are really bad. But when it comes to machines, you're pretty much getting one level. And once you get that point to a high level of accuracy, you can do that from anywhere in the world. All you have to do is upload a video, upload a picture, anything that could really help us identify, is this something of risk? And that's the other aspect, is we can also try to predict if there are other complications that they have to consider. If they have ADHD, should they consider OCD? Should they consider PTSD, depression, anxiety? Mm-hmm. Most of the treatments we have and diagnostics we have are for the symptoms, not the actual cause. And so we've been treating the symptoms for a very long time. We trying to get to the more cause. And so treating anxiety and depression are really the symptoms of many of these other disabilities and disorders that are falling behind.
Oh,
Arthur, just one is that triggered, is your analysis of the video triggered by the video itself or by audio cues?
Anything. So audio cues, video cues, and so someone speaking. The other thing is I also have dyslexia, so I've kind of gone through a lot of this myself. Had I been diagnosed earlier, probably would have been even better. But it hasn't really hurt me too much. I was lucky in that particular sense. But we can really use any cues that the machine can learn.
So you have AI tech that can watch video?
Absolutely. We have AI tech. We can also do this in a AR, VR environment. So we can actually put them into a particular VR space, have them interact and see without any type of social anxiety or learning disabilities in a virtual classroom. So we can really do all of this now completely virtually from where you live, from where you work, and be able to do this in a matter of minutes versus before it would take you 3-4 months of just diagnosing a child if they have autism or ADHD or not.
We have more questions, Arthur. Yes.
Sure. Good to see you, Arthur. Steve McCarthy here. It's been a while.
Hi.
He managed the panel with me way back when. Question for the panel. This actually comes out of a session I had with somebody else that Marty knows in this healthcare business. In terms of sourcing ideas, sourcing potential conflicts, so sourcing particular areas. One of the presentations I saw recently was a gentleman running developing a fund in terms of gathering the intellectual property of about 15 to 20 Midwest universities. And so part of my question is, do you find that when you're looking at entities to look at funds, is there a process by which you say, that's interesting because it's been incubated at universities, how do we get that out of there versus standalones? Because some of the universities may have resources that do a long time as opposed to standalone. So it's more about sourcing entities, and what do you think about the idea of using a kind of incubator fund, best and brightest, because the guy's got 75, scientific pros looking at Northwestern and Iowa and all these places for ideas in healthcare. Any thoughts about that, or does that make sense in terms of the question?
The answer is we pay a lot of attention to what they often refer to as tech transfer offices. So a lot of these institutions have offices that are built to commercialize the scientific innovations. The question for us as investors becomes, what are the exclusive and or license rights related to those technologies as relates back to the research institution? But a lot of the times it's in everyone's best interest for them to spin it out into a commercial endeavor, because otherwise that research is going to just sit in the lab. So the short answer is we pay very close attention to those.
And are some universities better than others in your opinion?
Some of them have a longer history of doing so, but I think to your point about looking in the Midwest, one of the things that we pay a lot of attention to is looking outside of the coastal areas for all things in innovation. I mean, a lot of our best, one of our sort of leading investments came from Kansas City, for example. So we're consciously looking in places where others aren't, and so I'm sure that would apply equally to tech transfer offices.
Other two gentlemen?
As I mentioned, we actually are in the process of finishing up a venture studio, and very much the idea is to bring brilliant ideas from universities. So we have very strong connections to universities both in the United States as well as abroad. And so one of them is Johns Hopkins, and we are based out of Baltimore, and so we have a lot of technology coming out of Johns Hopkins through our program. But what
Mr. Bloomberg should help you out there. I understand he has some connections. Mike Bloomberg.
Sure.
He runs the health school, for Christ's sake.
Right. So we absolutely look at what's coming out there, and then we also understand that they don't have all the tools or resources to actually build out companies. So they're really good at doing research, and that's about it.
Yeah.
And then so what we do is to try to identify experienced entrepreneurs, experienced managers who can come and actually take these ideas, build proper companies around them, and then we're able to fund them. And so that is something that we do actively, because a lot of what we do are very much in the lab. They haven't really been outside used by others, and that's the problem. Is when we tried to find these type of technologies, it was so hard because they were so stuck inside the lab. And because I had an academic background, I was able to jump into the publications, figure out who they were, and I was able to find them. But not everyone is able to do that, unfortunately.
Okay.
Just to add something there, Mahesh touched on a really interesting kind of emerging dynamic in venture capital. there's so much competition now between seed through Series B, pretty much from a capital perspective. You're finding a lot of venture funds are doing what Mahesh is referring to, which is actually starting to incubate the companies themselves. In part because you come out the other side with 50-60% equity as opposed to 10-15, and then you're in the prime position to build that out yourself. The trouble then is finding the right executive talent to kind of help you build that out and take it to the next stage. But I thought it was interesting you touched on that because it's certainly something that we're seeing from the, from in the trenches is that a lot of these companies are starting to think about studio models.
Okay. Thanks.
Great. Well, I will let Jeff talk about what do you guys think after all this COVID happening, and that was such a disruptive situation for all of us, right? And I'm pretty sure for healthcare in general. Yeah. What do you think? What's going to happen with all the we're talking about the future, right? So we have on one hand we have all the technology, but we also have people like yourself trying to figure it out how to pay for all this thing. And what do you think that the whole situation with the healthcare system in the United States is going to go? Because it's getting more and more expensive. I mean, on the other hand, the technology is pushing it down in terms of the cost, but then the actual the policies and programs are super expensive. So what do you think that what's the future holds for us?
Just a little context. So again, my experience is essentially a case study in home healthcare, and this company had 200 million of revenue, 10 million hours of home healthcare services, 8,000 patients, right? And I viewed it as a very valuable asset. They had the last mile, right? They had 8,000 patients that you can sell a lot of stuff to, including medication management, food services, transportation, etc. And this company was built based on acquisition. So 30 acquisitions, and the trick was they would buy them at 3, 4, 5 times EBITDA, and you put it on a platform that's worth 10 times EBITDA. So it was cool while it worked. And as I mentioned, when it gets too big and you don't have the right management and the right technology, it starts to be a challenge. A good question, because I landed right around COVID time, which was especially challenging to support patients, which we cared about, in that patients didn't want home health aides in their home. Home health aides didn't want to go to patients' home. Home health aides had to stay home and watch their kids because schools were closed. And the government was paying them more to stay home than to go to work. So it was an amazing challenge. And how CareFinders dealt with it is in a few ways. One is they cut big checks to home health aides, combat pay, appreciation pay, benefits, et cetera. So they went into their pockets, compressing margins. And then they got the whole home health care equipment, gloves, masks. They were kind of first to step up for that, again, compressing margins. Later on, the government came in and wrote a check to cover those costs. One early thing in a Medicaid situation, nurses are required to visit a patient twice a year. And what we're able to do is to set up a telenursing program where we're able to support those 8,000 patients through telenursing. But, these guys are really, what they're saying resonates, because I saw, and we talked about where technology could really, add value to these types of situations. One technology that I looked at just intellectually was a group in Canada that was able to monitor the movement of the patients. So, the kids knew when their mom was going to the bathroom, or if their mom fell, and it was a huge sense of relief for the kids who were looking after their mom. I think in terms of payment schemes, efficiency really matters. So when we looked at how much we were getting paid from the government to support patients, the subsidies kept going higher and higher. Some of it COVID related. Some of it was that the cost of a nursing home was so much more expensive than caring for your parent at home. And I think, in the future, you're going to see more and more home care systems. And just an add on to that, in Pennsylvania, for instance, the local governments are paying families to take care of their parents. So they're not having to go to nursing homes. So I think, technology is really important. I think it extends the quality of, enhances the quality of patients' lives, as well as brings down the cost.
That sounds good. Yeah, we'll see where everything goes, but I guess there's going to be that merger between the technology that will help out to do remote telemedicine, a lot of telemedicine, and also the self-diagnosis at home that could just improve the cost of all of those medical services, right?
Well, Arthur, 1 second here. I have to ask a question, and then there's a question from the audience, or maybe there's two questions from the audience. But my first question is, can you send me an article about that Pennsylvania paying people?
Oh yeah, absolutely.
That'd be great. And can you send me an article about this video recognition technology? Sure. Great. Question from the audience?
Sure, I don't know if your address is yet, but one of the things I see up my way and out in Long Island is the tremendous amount of merger activity in hospitals. Yale, New Haven is buying up everything. NYU Langone is buying up everything. How does that affect the way that you evaluate some of the companies that you're interested in backing? And that's kind of an overall policy of, M&A and whatnot. But is that cost savings? What's going on is my question from your point of view as you see these things merge.
I mean, for me, and I'm not expert in healthcare, but clearly the roll up of these institutions should result in more efficiencies and lower costs. It's not unlike what happened at CareFinders, where we started rolling up. We rolled up 30 companies into one, and a lot of that is because the smaller companies couldn't really keep up. They couldn't get the technology in place. They couldn't hire people, and so I think that great point. But what you're going to have is probably a little less competition, and in the short run, perhaps it reduces costs. In the long run, you don't have as much competition.
Right, gentlemen.
Yeah, I mean, in the sort of the macro context, as we're moving from a fee-for-service-based world to a paying-for-value world, and in that world that's definitely coming, albeit it'll take a while, being vertically integrated from a payer-provider standpoint, which is a lot of what's happening, helps to manage some of those costs and ultimately, hopefully, deliver better care for a lower cost. So that's a lot of what's happening. For our companies, the more the acquisitive environment, the better, right? We're trying to get these companies bought, or sold, or IPO'd. So to the extent the space in general is acquisitive, and to the extent that CFOs of large hospital systems are trying to buy companies, that's certainly great for us. One thing I would say, and just to build on that previous COVID comment, is that if you talk to any hospital system CEO, which we do all day, every day, the single thing on their mind at the moment is staffing. Yeah, COVID has absolutely destroyed hospital staffing models through nurse burnout, for the most part, and employee burnout. And that is all they can think about all day, every day. So kind of bringing it back to technology, granted we can't immediately augment a physician's abilities, but we're thinking about what technologies can we find that maybe better triage patients so we can keep people out of urgent care, out of a specialist office, and get a PCP to do some of that kind of work. So there's work to augment the sort of more fanciful sort of robotic work we can dream about to augment clinician and physician's abilities, but in the more short term, we need to find technology and solutions that kind of help reroute patients to lower cost settings and lower resource intensity settings. So that's something that we're thinking about a lot as it relates to COVID.
And I'm wondering, I just moved from New York to Connecticut, and I had to get new healthcare insurance, yes. and I couldn't believe how much I was paying in New York, but I never thought about it. I just and I don't like to pay anything. You go to a doctor, you don't want to pay anything. Just go in, and I think there could be a movement to share more of a sharing, that where insurance is real insurance. It's not 100% coverage for your health needs. And a lot of things have to come together because the demographics are not working in favor of reducing costs in healthcare.
And also, also the information, right? I mean, healthcare is full of these, information pyramids where information is shared with people. So people don't know how to get the best treatment, right? Because they don't have the money. And then, people who are over money, they have over worry about their healthcare, right? I mean, if you have like a concierge doctor and you have 24/7 rights to call them, you are calling them 24/7. I mean, it's, concierge doctors, they get people calling them all the time, day and night. I just sneezed, I twisted my neck walking up the stairs, I'm having a stroke, et cetera, right? So you've got this really crazy, world of some people get no health care and then people get too much health care.
I just wanted to ask Mahesh, just from the technology point of view, because I'm more so technologist. So any of your evaluation, the telemedicine, let's call it, right? Is that like, are you creating like hybrids between what you see in the video? I heard immerse word, word immerse. That's fantastic. But aren't there any like additional probes like in-house testing, like somebody? You mentioned DNA, right? And I assume that there is also the sputum or some simpler type of the samples that one can collect to detect certain ailments, right? Are those like is this how the new future medicine is going to work? So you have like an espresso machine at home, like thing that you stick out a specific test for your ailment, or not ailment, or you're going to test it outside of the video, or because there's only so much you can capture, I suppose, without probing certain human fluids, right?
Yeah, absolutely, and I think the video component is just one very small component of that whole diagnostic process. So that's just to see, and as I said, none of these are 100% accurate unless you do the full diagnostic testing. And so this is really just more to figure out what the possibilities could be rather than what the possibilities are. And so once you identify that maybe there are indications that this child might be in the spectrum, then you can potentially take them to a neurologist or an OT and have them test through a couple more assessments. And then eventually you can go through the genetic testing if it's needed. If it gets to the point that we have to have 100% diagnostics there, then we can certainly do the genetic side of things. So I don't think any of this is one and done. And this doesn't necessarily have to do with the neurodivergent space, really, but I do know that companies are working where you could go at least for the simple things like the common cold or some of the other types of readily available diagnostics, to just have something at home, and then you just do the test at home, and then you're pretty much 3D printing the whatever pill or whatever it needs to be at home. Now this is probably about 30-40 years away from now, but we do have all the capabilities of identifying the diagnostics, identifying the tools, and we actually even invested in a 3D bioprinting company that can really create at-home treatments, and so all those capabilities are there. It's really a matter of integrating all those different capabilities, and so that would be I think the future that we're expecting or hoping for in the next 30 years. But if you can do everything at home, that's great. Not necessarily having to cut out the physician, but you can do that from telemedicine perspective as well, or in a virtual environment or an augmented environment. So all these components are there, and trying to integrate them into the healthcare space is kind of where we're moving towards.
Yeah, Maxim, can you tell me like what's you're doing the you're doing investing? Are you doing a lot of investment into this sort of stuff, or the diagnostics and at-home diagnostics?
We don't do a huge amount of diagnostics themselves, and we certainly don't do, the only thing we pretty much don't invest in is biopharma, so no therapeutics. But we're certainly interested in kind of business models that involve getting diagnostics into people's hands through, let's say, consumer avenues, so sending test kits to the home and things like that. The actual innovations in the diagnostic science themselves is actually not something we do. We're not a kind of science-based healthcare team. We're very much a kind of healthcare business admin-oriented team. So I'm afraid I can't really touch on that.
All right. So what's the like a typical sweet spot for your investments? I mean, what do you do like?
So we write first checks of between $300,000 and $700,000. We can be the lead investment in that check, or we can follow. And then we follow on in kind of in a Series A round, kind of $1 to $2 million. That's kind of our two-check strategy. We feel like the first check buys us a kind of a front seat to the company to kind of see their progress over 18 months. Then we can kind of elect to effectively double down or not. Sweet spot is probably one contracted logo customer, enterprise customer for a company that's selling into healthcare. Preferably recurring, some form of recurring revenue. If it's a consumer model, then just very happy consumers who are renewing their subscriptions, if it's that kind of a model. And then from a team perspective, because again, we're mainly backing teams here at this point where there's not much flesh on the bone. Ideally, we like combinations of somebody not from healthcare, ironically, because oftentimes the less they know about the system, the better. Then it's also, particularly if the product is clinically oriented, having some form of chief medical officer or clinical buy-in from a clinical advisory board is something that we also look out for. So kind of, we try and, cherry pick some of those elements in the things that if I had to kind of pick an ideal investment, we obviously never get all of them. So it's usually a trade-off of, oh, this guy's got a lot of, or girl's got a lot of traction, but they have no clinical experience. And this person is a former CEO of a large insurance group, but doesn't have his first customer yet. So we're kind of trying to make trade-offs as to where that sweet spot is. And then from a valuation standpoint, anything below $15 million, and we can sort of definitely engage from a valuation perspective.
Are you always the first investor in?
Most often there's been a kind of angel round or a family and friends round or an angel group round. We are almost always the first kind of venture capital fund investor.
And it's all seed stage?
It's all seed stage.
Preferably convertible note?
We can do convertible notes, we can do priced equity rounds, we can do safes. Again, no real preference. If we're leading, we probably prefer to do a priced equity round, just so that everybody knows where they stand from a dilution perspective. But more often than not, the earlier rounds will be convertible instruments, and when we do those, we're perfectly happy to do so.
What's the size of the seed round?
Yeah, sorry, good question. So we're writing 300,000 to 700,000 in rounds that vary from 1 to 5 million. So in the smaller rounds, so 1 to 3, we can lead. In the bigger rounds, we tend to be a participant along with another fund. And on balance, we probably prefer to invest with other funds. We like to sort of bring in syndicates and people with specific expertise, such as Mahesh over here, if we're doing a newer investment. But we kind of like to build an investment group that brings something to the table. What we bring to the table, we like to think, is kind of access into the healthcare system. So we've kind of consciously designed our fund from a limited partner standpoint to be pretty much 50% family offices for whom healthcare is often a very personal story. And the other 50% of our investors are actually individual healthcare executives. So we now have, I think, 200 plus individual healthcare executives across our two funds. When I say individual healthcare executives, think captains of the US healthcare system. So hospital system CEOs, insurance executives, physician owner operators, people who are actually in charge of buying the technologies that we're investing in. So we've set it up such that ideally it's mutually beneficial for our LPs to do business with our portfolio companies and vice versa.
And what do you see as the uses of the $1 to $5 million? Is it R&D or, I mean?
Good question. It's usually fulfilling pilots and commercial agreements and staffing up for those and integration costs. On some of our more technologically kind of out there ones, it's some R&D, but for the most part, it's more commercial budget. And what's generally happened at Seed is they kind of, we refer to something that's called product market fit, which is you've made some product that actually has a fit in the market, obviously. Usually at Seed stage, they've proven that with one business or one commercial agreement, and the money is to go and prove it over again with another 5 or 10 customers.
Right.
So it's really to fund those.
How important is the business acumen of the founder group? Like that, at least one person knows something about business, because I mean, if you look at funding in healthcare VC, typically it tends to scale a little bit higher than in tech VC. So like tech is typically 35 and under, healthcare is typically 45 and under. And so, I mean, is it because somebody has more experience, it requires more education, you have to navigate payors and distribution? I mean,
yeah, we sat from an age perspective, we had everything from 23-year-olds to probably 75-year-olds. I mean, it's a really wide range. I think healthcare breeds that. It also breeds a really diverse set of founders because again, everybody is involved with healthcare at some point in their life, and so everyone gets that spark of, oh, I should solve this problem by building this business. What we're looking for is, at least if they're not from healthcare, then at least some understanding of the kind of pipes of healthcare. As we all know, incredibly complex industry. And if you don't have a deep appreciation of the incentive structures in place, then you're probably going to butt your head against the wall for several years. So part of our due diligence is getting comfortable with the entrepreneur's comfort level around how kind of the healthcare system works. And that's just testing their assumptions with questions we bring in. We leverage our limited partners on the front end of the process as well, whereby we can bring in experts from various parts of the healthcare system to kind of test some of these founders on some of the claims they're making or their understanding of the system.
So actually,
one second.
But they're specialized in taking the mRNA or RNA platform with, one with Nobel Prize winners to, from essentially in vitro, post-in vitro and animal testing those platforms into either cancer or viral diseases, including COVID.
Actually, are there?
Are there people as well? Because it's big money, right? I mean, take it from there, you have a cocktail that's proven in the lab and proven on a few rodents. Now you're looking at, $500 million to finish up phase 1.
Sure. So my previous company was actually in the nucleic acid space. So
that's exactly
right. And so nucleic acids have very different factors. So one is mRNA, and then there's a whole aspect of RNAi, so RNA interference. So there's siRNA, miRNA, all that. And then you have DNA. That's a whole other category. And there are companies that are working on all three aspects of nucleic acids. And so there certainly are successful companies that are working on each of these different aspects for different indications. So oncology and infectious diseases are leading the way because they're easier to target. There are companies, and one of them even tried for COVID is Neuvation. They've been trying to develop DNA vaccines for various different viral diseases that no one else is looking at, like dengue, chikungunya. It doesn't really affect first world countries, but it tremendously affects third world countries.
Are those the guys out of Philadelphia?
They started in Philadelphia, now they're in California.
Okay.
But then certainly with Moderna, they started off as oncology. They actually had nothing to do with infectious diseases until COVID happened.
that's
right.
Right.
And so there are a lot of schools of studies around that, and there are also companies that are working on viral side of things. So using what we call adeno-associated viruses or lentiviruses, so using viruses to kind of kill other diseases, and that's kind of where the CAR T technology kind of came from. It's a engineered HIV virus that can go attack cancer cells and kill it. And so there are a lot of different ways of using it. It's really the efficiency is still very low, to be honest. And we've seen that even with annotated viral vaccines, they're a lot better, a lot more effective than mRNA vaccines. And so there's still a long way to go for them to be adopted across the plane. But I think COVID definitely sets the stage for what nucleic acids can do.
More on the treatment side rather than the vaccines.
Yeah, absolutely. On the treatment side, it really comes down to, with mRNA, all it can really do is express proteins. That's the only job. And so as long as the disease has an aspect of protein expression, protein integration, protein destruction, anything like that, then we can do that. But not, only about 12 or 13% of the diseases fall into that category. Most of it's really something else is happening downstream or upstream. So they're more genetic than they are expression issues. And so that's where CRISPR and ARCUS and some of the other gene editing components come in. mRNA nucleic acids cannot do that. They don't necessarily fall into gene editing. They just express things. And so there are therapeutic applications, so you can certainly for one, one of the companies that's working on this is it's in diabetes. So expressing, going back on insulin. So just expressing insulin inside type 1, type 2 diabetes patients who aren't actually producing their own insulin. And just having them express it using mRNA is a very simple method of going after it. And there are companies working on that. And then same thing with sickle cell anemia, just expressing the right protein so that it doesn't have the moon-shaped blood cells. So there are multiple applications. It really comes down to what is the real problem around that disorder. And so mRNA doesn't necessarily have a huge implication in neurodiversity, for instance, or we haven't found one yet. So if there are problems with protein expression that we can find in some of these indications, and we're working on it. We're trying to find if ADHD or dyslexia or autism, it has any type of protein expression issues. If that's the case, then mRNA or other types of RNA would be a great way to interfere and intervene, I should say, with those type of therapeutics. But I think it's still a long way to go. I mean, mRNA, technically we've only known for about 20 years in terms of how to make it work, which is a very short time in biotech. So, DNA we've known for about 50 years, we still haven't done anything with it. So we're slowly going to get there, but I don't think you can't expect it to be as fast as what we did with COVID, only because we've been studying coronavirus for a long time, so we knew what to do right away. But we can't just bring that up for every other disease. Everything works very differently, and it's not just about expression. It's very hard to use those nucleic acid type treatments.
There's about 5 minutes left. Can we keep on going? Arthur?
Yeah, I just wanted to ask Maxim yet about more like a valuation of the companies, because currently in order for you to do any kind of like a pre-FDA test for any one of the company just to prove the viability of the product, it's about $10 million, and then in addition you have to probably spend an additional 10 to 15 to have a first level of FDA approval. So if you get a seed money in the level of $2 or $5 million, like initially, what is it that money could buy you nowadays?
Yeah, I mean, you can get to FDA. Is this on? I can't remember. Yeah. You can get to FDA approval for a lot less than $10 million. So most often, if we're investing in an FDA-cleared product, the seed round, part of those proceeds is funding the trials to get the approval. So I would certainly say that $2 to $3 million for a 510K clearance is
Really
cool.
Including clinicals and all that.
Yeah, and again, depending which FDA pathway you're pursuing, right? So if you're doing phase 1, 2, 3 clinical trial, that's a whole different story. But on the device side, which is kind of what we invest in, 510K de novo, you can usually get there for 5 million and under. And from a valuation standpoint, I mean, the truth of the matter is it's art over science at the seed stage. And it's some combination of the quality of the team, the amount of commercial progress they've had, and candidly what other companies are getting funded at in the market that day, month, week, right? I mean, it's you pretty much know where a company sits relative to the market, just given how many we talk to. I mean, I must talk to 1,000 companies a year. We probably make 10, 12 investments a year. So relatively active. So we see a lot of companies, and you get a pretty quick sense from that kind of pattern recognition what feels expensive, quote unquote, or cheap from a valuation standpoint.
All right. Well, Jeff, if I wanted to kind of wrap it up and see what are your thoughts, like what's exciting and coming in the healthcare business? What do you think that what the opportunities are?
I mean, if you look at every other sector, right, the internet has indelibly penetrated it and changed its nature, right, and what our experience of that industry for the most part, except healthcare, right? So I mean, we are in innings 1 of the transformation of healthcare technology, and I'm involuntarily smiling because it makes me excited for what's to come, and just the sea change of innovation that we're going to see in healthcare over the next 10, 20, 30 years, I promise you will be unrecognizable from the healthcare that we know today, let alone yesterday. So I just want to leave you with one thing. Change is coming, and it's exciting, and it's hopefully going to make things, first of all, cheaper, and second of all, better outcomes for patients.
Do you think we need to get rid of the privacy issues as it relates to Medicare, medical stuff? I mean, that's a big issue.
You couldn't have asked me a better question for our portfolio. We invest in a company called Triple Blind. I encourage you to look them up. They have figured out how to cryptographically share healthcare data across systems providers.
That's a huge issue.
This is a huge issue to collaboration and to kind of advances in technology. But I can assure you that people are working on that exact problem and are currently in the process of solving it. Thanks.
Okay.
Jeff, what are your thoughts for the future?
For future, again, not being the healthcare expert, but just from my experience, it's the demographics are moving toward people getting older, people are requiring more care, care at home being, a concept that is going to, win the day. And for all of these technologies that these guys are working on, there are plenty of users that, that need them. And I'd encourage them to, so that the company that bought Care Finders is a public company called Motive Care. They have 20,000 patients now, when you consolidate and roll things up. Their business was in transportation management, so they would take aides to their doctor's appointments, et cetera. But there is an intense need to support these 20,000 patients with, various technology. What resonated was the medication management. So I wish everyone luck here. There's plenty of money, by the way, chasing this space. So, when you get past the VC, the PEs, when we kind of sniffed that we were interested in looking at opportunities, 5 big PE firms came to the table with LOIs in a matter of a week, okay? And they were any numbers that we wanted. Now, they'll tell you any number that you want, and then you start negotiating and getting it down to real economics.
Mahesh, any cure for cancer?
Well, I don't think cancer can be cured per se. I don't think at least that particular word can be used for cancer, only because, again, the genetic aspect. I don't know if all of you know this, but all of you have cancer. Your body just fights it before it becomes a tumor. Right? So there's no cure for cancer. It's actually evolutionarily important for you to have cancers. It's just trying to identify them earlier and killing them sooner if they get to a tumor size. I think that's where we are, is we can identify them faster. We can get to treating them sooner with better treatments. And as Maxim and Jeff said, it's about efficiency and getting better quality out of those type of treatments. And what's going to help, I think, at that point is the digitization of things, as well as bringing in blockchain and kind of looking at the security side, but also looking at accessibility. So a lot of what we're focusing on is very much in the developed countries, kind of bringing that over to underdeveloped countries and bringing access to them as well is going to be important. And we've seen that with things like coronaviruses. You can't just isolate in one place and then try to, not have everyone else come in. That's not how biological works anymore. It's a global world, everyone's traveling. And so we can't just isolate things anymore like we used to. We used to be able to do that, we can't do that anymore. So if you're getting treatments in one place, part of the world, you have to really be able to bring it to all parts of the world and treat it equally, or it's going to keep coming up in the future. So being able to have a global approach to any type of medication, any type of device development, any type of technology is going to be, I think, the future of health.